And thank you for Danielle sharing her story as well. It's often hard to share your personal story, so thank you. I'm going to invite up our ovarian cancer panel. And we have a great group of experts, led by Dr. Andrea Jewell as the moderator. We have Dr. Jodie Barr, and we have Katie Nelson again. All right.
Okay. And then do we have a clicker?
Very
Wonderful. Hi, everyone. I'm Andrea Jewell. I'm at the University of Kansas, and we have Dr. Jodie Barr with us from Lawrence Memorial, and Katie Nelson, one of our genetic counselors. So we're going to start. So we have a 68-year-old who presents with bloating, abdominal distension, medical history of hypertension, surgical history of an appendectomy, nothing significant in her GYN history, and no significant family history. And so I'm going to start talking about surgical management of ovarian cancer, and then we'll kind of transition into some other maintenance therapies and genetic screening. So what's our goal of surgery? To get everything safely out is kind of where I start with, and the goal of chemotherapy is to kill any of those microscopic cancer cells that are left. This is a slide that's formatted a little funny, but this is one of the things I always talk to my patients about in regards to survival, and how we're really battling ovarian cancer is a combination of aggressive surgery and new targeted therapies. And so, in the 80s, average overall survival was about a year. And what we've learned is that through more aggressive surgery, optimal debulkings, no gross residual disease, and then addition of other types of chemotherapy and targeted agents, that has been steadily increasing over time. And so ovarian cancer is a peritoneal type of malignancy, and so it's confined to the abdomen, and it typically doesn't deeply invade into the abdominal tissues. It's surface involvement. And so here's an example of, you can see the ovaries that are there. On the left side of the screen is like towards the feet, and so there's the uterus, tumor on the bladder, tumor on the bowel. And we will do large in-block resections of bowel, uterus, ovaries, even parts of the bladder to get all of this out. And then you can see here that the pelvis is completely stripped there of any of the cancer. And so what is the impact of having any residual cancer? And what the data has shown us is that getting down to no gross residual is ideal. And so, what you're seeing here is that those patients, 0 millimeter, significantly better progression-free and overall survival compared to patients who we call optimal if it's less than 1 centimeter. And so there's still a survival advantage to that compared to suboptimal, but there really is a significant advantage to no gross residual disease. And that's really our goal, and that's a lot of what our medical oncologists talk about when they're meeting patients to talk about, do we start with chemotherapy or do we start with surgery? And then this is, there we go, this is just looking at a few different trials, and again, you're seeing patients that are not optimally debulked, much lower overall survival, and then GOG 172 and follow-up of that. Patients that had no gross residual disease, we were seeing overall survivals of 127 months. So I mean, that's essentially unheard of from what we saw even just 20 years ago. So CAT scans are not perfect. That's the thing I say a lot in clinic. CAT scans are not perfect. And so what does that mean? Well, sometimes a CAT scan can definitely tell me if I can't do surgery. So like if you have cancer in your lungs, or if you have cancer in your liver in an unsafe place that I can't surgically resect, then we know we should start with chemotherapy. But sometimes CAT scans look like, hey, we could probably take all this out, and then you go in and you can't. And they have a big open incision, they need to recover, you're starting chemo. And they sort of end up having to recover from 2 big surgeries or 2 big incisions. And so in Italy and at MD Anderson, they've developed a laparoscopic scoring method for us as surgeons that we essentially can put a camera in, and we can look around and say, does this look like someone that we can safely and optimally debulk? And if it's not, then they haven't undergone a huge procedure. And this has been validated both in Italy here and in the US. And this is just the kind of scoring algorithm that we use. And it's been validated multiple times, and so it's something that GYN oncs are trained to do, and it is a big thing that it's always GYN oncs and med oncs should always be working together. And we have a great history of being able to do that with a lot of our med oncs in the community and working together. But these are some of the reasons, because GYN oncs understand the radical surgery and these different scoring methods and important things that would need to be done to help with the overall survival of our patients. And so what are some new surgical and advances? And so maybe you guys have heard of hypothermic IP chemo. So HIPEC is what we call it. And this has been something that's been done but not adequately or prospectively researched in the past. And so from the Netherlands a few years ago, they actually came out with a study. Now, these were patients that all got interval surgery. So these are patients that came in, started with chemotherapy, after neoadjuvant chemotherapy had surgery. They were divided into two groups. One got that heated IP chemo during the surgery, the other did not. And what this study showed us is that progression-free and overall survival was improved with HIPEC chemotherapy. But oh goodness, you go to a conference and everyone gets very intense about HIPEC chemo because patients can't tolerate it. It's very toxic. There's a lot of anecdotal concern about that. Well, the study actually showed us that the toxicity was the same in both arms. So patients tolerated it just fine. They got to their chemo afterwards just fine. And so there was a lot of anecdotal concern about it, but this is a large prospective study showing us that there could be a benefit to adding HIPEC to interval surgery. Well, what if we added in the upfront? And this one just came out recently. And so this was a study that did HIPEC in primary surgery patients and also interval debulking. These are kind of busy slides, but the take home here is that patients that got HIPEC with primary surgery, it doesn't necessarily look to be as much of a benefit in those patients. So we should probably be tailoring this to our interval debulking patients. And I'm on the NRG Ovarian Cancer Committee, and we're working on designing a study here in the US looking at this and looking at different maintenance therapies. Insurance covers this, I can tell you that, because at KU we actually have a trial right now and we offer this to our ovarian patients. Insurance covers it. I think it's very reasonable to offer this to your interval debulking patients, and they should definitely have a conversation with a GYN onc if they're a good candidate for this, because there are some other specific criteria. So we have our patient, she's gotten chemo, she's gotten surgery. How do we follow her afterwards? And this is something we're asked about a lot. And this was a study where they actually looked at following CA-125 levels or blinding physicians to CA-125 levels and only managing patients by symptoms. And what they found was that CA-125 actually does not improve progression-free or overall survival, and it actually decreases their quality of life. That being said, I would say the majority of ovarian cancer patients will have you stop that CA-125, like you'll have to pull it out of their hands. But this is something I talk to them about a lot, is that there's a lot of stress with following those markers, and trust your body. Like your body has symptoms. We're gonna take everything seriously and work it up. This is a hard one though to convince people of, but I do always like to show that because it is something that we're asked about a lot, and it does not impact their overall. So we talked about these. We do primary versus interval surgery, and then who's developing ovarian cancer, and this is now we'll move over to genetics, and that's 15% of ovarian patients. It's known to be associated with a genetic risk, and then 85% are spontaneous.
Thank you. So I am just going to get started in going over that all of these national organizations, ASCO, USPSTF, NCCN, SGO, and ACOG, all recommend universal testing for individuals that have ovarian cancer. But the amount of patients that are actually receiving this service is very varied. So anywhere between 39% of individuals with ovarian cancer are actually undergoing counseling and testing testing services when there's no interventions in place. And then on the high end, 99% with mainstreaming, which is more of the provider being able to order that genetic test at that first touch appointment. Other abilities such as telemedicine, embedding a genetic counselor in your clinic can help improve getting patients to get genetic counseling and testing. But this just shows that there has to be more done to get patients to actually have this service, which is extremely important in being able to know the correct either managements that you can offer the patient and anything else that we can be doing for the patient to prevent any other cancer diagnosis. Really, the who needs to have genetic testing. Any woman with epithelial ovarian cancer, which I have some of them listed there, as well as fallopian tube and peritoneal, primary peritoneal cancers. I would also really encourage the sex cord stroma tumors as well, having a genetic counselor. There are other genes such as Dicer1, Peutz-Jeghers STK11 gene, that can cause these other rare types of tumors, and having a genetic counselor really take a good family history. Not all labs offer Dicer1 testing, so making sure that we're using a lab that can actually assess for that mutation as well, because these would also have other types of cancer risk, breast cancer risk, colon cancer risk, pulmonary tumors. So what else do we need to be doing for this patient or their family members based on these hereditary risk factors? And then when should genetic testing take place? That is going to greatly depend on your facility. So really, the earlier this process is started, the better. There is a debate within professionals of whether or not we should be ordering small testing to begin with, BRCA1/2, as that's what's going to be impactful for that patient's immediate treatment, and then maybe doing larger panel testings later, where other thoughts are just doing everything at one time, so you're not having to get that patient back in for having another test, so not having to have someone really track down to see what's been done, but just doing one test all at once. And so I think the main thing is just who is going to own that responsibility of following up with that patient, who is going to take charge in your clinic to make sure that the patient has gotten all the testing that they need or has been referred on to that provider who's going to do that genetic testing for them. And really, how are we doing genetic testing? Genetic testing can be done by genetic counselors, physicians, and nurses, all with experience in cancer genetics. It can be done concurrently with somatic and germline testing at the same time, so a companion diagnostic test that can maybe also look at other things such as homologous recombination deficiency, thank you. Genomic instability as well, so looking at other markers within the cancer that can help give somewhat of a better idea of what is the makeup of this cancer, or depending on the facility, maybe somatic testing first is what's going to have to take place, because there is maybe not the ability to get that individual into a genetic counselor quickly enough. So getting that somatic information to make those treatment decisions, and maybe once things have calmed down for that patient, getting them into a genetic counselor for that full panel testing. Or maybe it's the opposite for your facility. Maybe you have a genetic counselor who is very available and can do that germline testing first, and then when the patient is actually going through their surgery, can do that somatic testing later. So it just depends on what your resources are. There's not really a right or wrong way of which option. It's more so whatever is working with your facility, whatever you can be able to get that patient at that time. And then utilizing physical or electronic screeners, as well as these bots that we've talked about in a previous lecture, and being able to automate a lot of these processes, getting that family history, being able to see this information across multiple patients. So Ambry has a care program, Invitae has a GIA bot. And so talking to these labs about how can they make these processes easier within your facility to be able to get the information, the family history, as well as giving that patient some genetic information, so that then when they're meeting with you, with their genetic counselor, they're prepared to have those discussions and know what they may want for their testing. And so let's come back to our patient. Again, she is 68 and really did not have any family history information. Lost contact with her paternal side, so she doesn't have any medical history on her paternal side, or even if they're living or passed away. Her mother's an only child. There's no known Jewish ancestry, but still, based on her diagnosis, she meets criteria for testing. So we do both somatic and germline testing, and her somatic results reveal that she does have a BRCA1 mutation, but her germline testing is completely negative. And so a very important conversation with this patient that these results can still impact her treatment, her management, but then something that her other family members do not need to have testing for. This is not a mutation that she was born with. This is not a mutation that she's going to pass on to her children. And so being able to help explain that difference between these two different tests and how this information is still guiding her doctors, but not something that her other family members needs to go and have testing for. And I think that's just a very important point with tumor versus germline testing. When germline testing is indicated, it needs to be done through a lab that is CLIA approved and who has a lot of experience with doing germline testing. Somatic labs, their germline testing, it just has different criteria of what they can call pathogenic or benign. They're more so looking at treatment options instead of hereditary risk factors, and just have different thresholds for when they would call something a germline mutation or a somatic. And the rate of finding a BRCA1 or 2 mutation without a germline mutation is 7%. So just because we're finding a BRCA mutation in the tumor, that does not automatically mean that this patient has a hereditary condition. We would still need to do that germline test to verify before we're recommending family members have testing.
All right, so great segue into what do we do with those patients after their therapy. So we're going to talk a little bit about maintenance PARP inhibitors. So what exactly is a PARP inhibitor? So as we were talking about, for example, this woman has a somatic mutation. So her cancer cells are unable to repair their DNA. So the PARP inhibitors come along, they create double-strand DNA break, and so they can't repair that, thus those cells die. So that's how the PARP inhibitors work. Who qualifies? So which patients are you going to think about PARP inhibitors? Again, this is post-primary treatment, so patients with stage 2 to 4 disease, but that data is a little bit less robust in stage 2 disease. Also, your histology is going to be high-grade serous carcinomas, grade 2 to 3 endometrioid, or in those patients that are BRCA1 and 2 mutated, and clear cell carcinomas or carcinosarcomas. These patients achieved either a complete response or a partial response after their primary treatment with surgery, and then they had platinum first-line therapy. This is just a table looking at what are our available therapies. So we have olaparib with bevacizumab versus olaparib monotherapy, and you can see the doses there. We also have options for niraparib and rucaparib monotherapy, and we'll go through each one of those in the studies. So first of all, let's take a look at those women that actually have a germline or somatic BRCA1 and 2 mutation. This was a SOLO-1 trial, so these were all phase 3 double-blind randomized trials, again looking at newly diagnosed women, stage 3 or 4 disease. These women had mutations in BRCA1 and BRCA2 or both. They had complete or partial response, again after platinum-based chemotherapy, and they were randomized to olaparib 300 milligrams twice a day versus placebo. So as you can see here, both by investigator and central review, that progression-free survival was statistically significant. There was a 70% decreased risk of recurrence and death in the olaparib group. As you can look across the subpopulation, all of those women derive benefit from olaparib. So what about those women that are BRCA1 and 2 wild type or unknown? Is there any data for using PARP inhibitors in that population? So this was the PRIMA trial looking at niraparib. Again, very similar design. They were randomized to niraparib 300 milligrams once daily or placebo. At the endpoints, though, looked at progression-free survival in those patients with homologous recombination deficient. What do we mean by that? It just means that they don't have BRCA1 or BRCA2, but they're still unable to repair their DNA. And then they also looked at progression-free survival in the overall population. So as you can see here up in the top left, that's in those patients that are HRD. Again, that was statistically significant. There was about a 22-month benefit in the niraparib group. But also in the overall population, just not as great benefit. Again, in those subpopulations, we did see benefit, except for those patients, maybe less, that have homologous recombination proficient tumors. So there is an option to actually observe these patients, but niraparib is the only PARP inhibitor that's approved, again, in women that are BRCA1 and BRCA2 wild type. So what about those women that got bevacizumab as used as their primary treatment? They had germline metastatic, again, BRCA1 and 2 mutations, and were HR deficient. So this was a Paola trial, again, very similar, but they were eligible regardless of their surgical outcome or BRCA mutation status. They were also randomized to olaparib 300 milligrams twice daily or placebo, along with maintenance bevacizumab. So as you can see here, they did derive pretty significant benefit, specifically in those patients, again, that are BRCA1, BRCA2 mutated, and that were HRD positive. A little bit less benefit, again, in HR proficient tumors. So those patients would actually recommend just continuing with maintenance bevacizumab and not with PARP inhibitor additional. What about PARP inhibitor first line? So this trial looked at adding olaparib with your upfront carboplatin paclitaxel base therapy, followed by maintenance monotherapy. So as you can see, across all the population and the intention to treat, there was some benefit, but the question in this trial, it was essentially, were we getting more benefit from the maintenance therapy and not adding it up front? These patients also had significant GI toxicity and myelotoxicity, so we don't use the PARP inhibitors in frontline therapy at this point. And again, you can see the subgroup here. So again, just busy slide looking at, these are all the trials, but really the big take home from this is mostly the big bang is gonna be BRCA1, BRCA2 mutated, along with patients that have HRD. That's where we see the most benefit, less benefit in those patients with HR proficient. So just a little, the Olympia trial in breast cancer also took a look at BRCA1 and BRCA2 mutated breast cancers, and is there benefit with adjuvant olaparib. So these were actually HER2 negative women. They could be estrogen, progesterone positive, but they were higher risk women, so larger tumors, node positive disease. And they actually showed benefit that was statistically significant in disease-free survival, as well as distance disease-free survival, but no benefit at this point in overall survival. And you can see the subgroup population there. So that may be something, again, in those patients that are BRCA1 and BRCA2 mutated to look at in regards to PARP inhibitors.
Allergies, I promise. Yeah. I feel like I'm coughing at this time. Oh my God. So one of the questions we were asked was clarifying about the CA125. So are you saying it isn't needed for the high-risk patient, like someone with a BRCA mutation, or just not in surveillance? And so we're talking about surveillance for ovarian cancer patients. It's a whole other conversation to talk about how effective CA125 is in screening our BRCA patients. We don't have a great way to screen for ovarian cancer, and that's why we talk about surgical risk reduction, and that would be kind of a whole other topic. But NCCN guidelines do recommend in premenopausal patients, you can add it or not add it, definitely surveillance ultrasounds. In postmenopausal patients, they do recommend for patients that have not had surgery yet or not ovarian cancer, that you use that to follow. I'm gonna try and go through, like, ovarian cancer comes back, and we know that about 80% of ovarian cancer patients come back. I think it's gonna be really interesting in the next 5 to 10 years to see what PARP inhibitors are gonna do for that. I think we're going to start seeing more and more patients that are getting farther and farther out, and we might be seeing some higher cure rates. But one of the big things is, should we be operating again? And this is something that is a hotly debated topic, and we have a lot of retrospective data. Essentially the same thing: if we can't get it all out, we're not doing you a benefit. We know when it comes back, we're really not doing you a benefit if we can't get it out. So it really needs to be the right patient that you're going to consider to operate on again if they have cancer that's come back, because you're gonna harm a patient or like decrease their overall survival if you're not treating them with chemotherapy or other targeted agents and you're operating on them. Basically, we've had 3 big trials that have looked at this, and there's a lot going on in this slide, but what I'm talking about here is kind of looking at these 3 different trials and, seeing that you're never supposed to do cross-trial comparison, but we're looking at similar populations here. And then we're looking at overall survival as a primary endpoint. And so you're seeing in the surgery group of the 3 different, 213, it was 53.6 months, desktop 53.7, the SOC trial 58.1. What we saw in 213 is that the patients that didn't have surgery, while not statistically significant, did better. And then similar in the SOC1 trial and desktop 2, it looks like there was actual decrease in the no surgery patients. So then we do some subgroup analysis. This is progression-free survival. And essentially, what we know is that when they look at subgroup analysis of no gross residual versus, we call that optimal, the even less than 1 centimeter, those patients were not deriving benefit. So we're really not helping patients unless we can get everything out. So the ideal patient here is someone who's platinum sensitive. It's been greater than a year since they've had chemotherapy. They have a localized recurrence that's in a place that you can safely get out. If you're not, the data has really robustly told us we're not helping those patients by operating on them. And it's hard because patients come in and they're like, well, just take it out. You should just take it out. But we now are getting consistently more and more data tell us we're actually not helping patients by doing that. And so that makes the conversation a little bit easier to say we really need to be looking at other agents, other chemotherapy, other things like that. Those are going to be more beneficial. Does anyone have any other questions? Yeah. Yeah.
Is yours on? Oh, no, they turned it on.
Okay.
So, Dr. Barr, could you speak to how are you deciding which patients you're testing for BRCA1 and 2, given that we now have an approval for adjuvant PARP? How are you deciding, because not necessarily all of those patients would qualify for genetic testing just based on their diagnosis. So how are you deciding which?
No, they would.
Yeah.
Would.
I'm so sorry, for your breast.
Oh, for breast,
Okay,
I was like, no, it's approved.
No, I was like, no,
Sorry.
test all your ovarian cancer patients.
Sorry. You commented about the approval of the
Yes,
adjuvant PARP
yes.
for the breast patients. So how are you deciding
Yes.
which of those patients to test? And yeah.
So,
Sorry,
we have the NCCN, I think, has not caught up with American Surgery, whatever, the surgery. So, sorry, that big, Dr.
Yeah.
Wasley can tell me that. Anyways, they recommend that all breast patients, get testing. So I sit down and talk to all my patients about an option. Most of these companies, out-of-pocket cost is very, very reasonable. So we go through risk and benefit. What does genetic testing mean? What does that impact? We start talking about, does that impact, PARP inhibitors or sometimes those therapy up front. So I think it's coming down the horizon that we will be testing all of our breast patients.
Thank you for that.
Yes. All right. All right, if there's no other questions, we can thank our panel. Yay.